Hello, everyone. Welcome to the WBMT webinar on BMT access in conflict and war zones, extreme challenges in equity. I am Adriana Seber from Brazil, and I'm very pleased to welcome you all here to this meeting. It was organized by Dr. Nada Hamad and the Education and Dissemination Committee of the WBMT, Worldwide Network for Blood and Marrow Transplantation, that is shared by Dr. Damiano Rondelli, who's now our president, Dr. Niederwieser, and me. And this webinar will have two different parts. We have 3 talks and then a panel discussion. The talks will be first the Ukraine experience by Dr. Irina Korenkova from, I'm sorry if I misspelled someone, and from the Kyiv BMT Center in Ukraine. The Gaza experience by Dr. Amer and Dr. Ode from the Al Nahyan National University, Nablus, Palestine. Then the role of BMT organizations and the WBMT from Dr. Hamad from UNSW Sydney, Australia. And we'll have a 20-minute panel that will be led by Nada Hamad, and we'll have participating Dr. Amer Stratos from Geneva, from the WHO in Geneva, Switzerland, Dr. Shahrukh Hashmi from the Abu Dhabi International, but now from Abu Dhabi, Dr. Estomen from Ukraine, Kyiv, Dr. Irina from the Kyiv, Sylvia Montoto from United Kingdom, Razan Ode from Palestine, and Salwa Hassalat from Amman, Jordan. So I thank you very much for your participation. Today is July 17th, and this webinar will be recorded and posted in the WBMT website, so it can be watched later. Thank you very much, and I would like to invite Irina Korenkova to give the first presentation. If you want to share your screen, we'll take this out. You'll talk to us about the Ukraine experience. Thank you very much, Irina. And I would ask all participants if they can close their audio and video, then we'll have a better sound. Thank you so much.
So, hello, everybody. And I will tell some words about experience, Ukrainian experience in BMT. So today is day 875 of Ukraine's heroic resistance to Russia's full-scale military aggression, and 10 years of occupation of Crimea and part of Donbass. And now Ukraine's total economic, social, and other losses amount to almost 500 billion as part of the end of year 2023. And the sectors of trade, industry, agriculture, energy, and transport were the most affected. And the amount of direct damage caused to the infrastructure of Ukraine during the war reached almost 155 billion as of January this year. And the damage to healthcare infrastructure is more than $3 billion. And what is also very important is Ukrainians' human capital. The population of Ukraine was 41 million people, as we know, on the year 2022. But at the end of January 24, there are 4.9 million Ukrainians abroad because of the war. And the number of officially registered and internally displaced persons in the country reached 4.9 million people. And of these, 2.5 million have been displaced and cannot return to their homes because of the home is either destroyed or located in the zone of active hostilities or in temporarily occupied territories. And during more than 28 months of the war, Russian shells rockets destroyed a total of 214 facilities of medical institutions, which cannot be restored, and another 1,630 medical facilities were damaged. And damaged also 180 emergency medical vehicles, destroyed 261, and seized 125 emergency vehicles. And what is very important for us is that 128 deaths and 288 injuries of medical personnel, as we know, at the beginning of April for this year. And on the map, you can see the attacks on the health facilities in Ukraine. And damage to hospitals and health facilities was most common in the oblasts along the front lines and adjacent to Russian borders. And these hospitals were attacked with artillery, aerial bombs, like drone attack from the plane, cluster bombs, mines, missiles, rockets, and so on. And you can see that whole Ukraine is under this aggression. It's no safe place in Ukraine. And challenges that we faced during the Russian invasion, it was recently published. And you can see that the first and most important is equipment supply, laboratory tests, delivery of the drugs. It's supplies of consumable medical resources. It's, of course, our scientific resource stopped, no clinical trials. Also, it was problem with the vaccination. It was healthcare services for older adults. Insurance system was also injured, and as you can see, blood support was also a big problem. And challenges for Ukraine now is that attacks on infrastructure continue. We lost young population. We also have decline in birth rate. We have a shortage of qualified personnel in general, including hospitals. We lost energy infrastructure, and we also expected shortage of electricity. We have decline in our gross domestic product. We increase also in population poverty, and Ukrainian currency devaluation led to increase of price for all needs, including medical devices and supplies. And also we have a big logistical problems, such as broken supply chains, cold chains difficulties, and air traffic stop. We have no air communication from the beginning of the war. But we are alive, we are continue our work. And I will say a few words to you that up to year 2021, it was only minimal activity in stem cell transplant in Ukraine. In 2019, it was only 97 transplant autologous and no allergenic, zero allergenic transplants were done. But the development of transplantation became possible due to adoption and funding of the transplant program in Ukraine. In 2021, we saw the increase of autologous transplant, and it was also 6 allergenic transplants performed for adult patients and 39 for pediatric population. And in year 2021, the European Leukemia Net and Worldwide Network of Blood and Marrow Transplant were asked to support the Ukrainian lymphatic stem cell transplant program for adults. And the daily supervisory telemedicine rounds were initiated and continue until now. And after the beginning of the war was created a very huge and, as for me, very important organization, Help for Ukrainian Hematology Patients. And you can see how a lot of patients included in this process, and which and how many organizations also take part and support us. And this network was launched with the participation of the Ministry of Health of Ukraine and World Health Organization, with the mission to establish sustainable care for hematology patients. And since February 2022, the weekly video conference meetings have focused on addressing major barriers to hematopoietic stem cell transplants in Ukraine. And what we receive: weekly tumor board with global experts. 41 patients received treating plan and place for treatment. We also received support to the Ukrainian unrelated donor search. A lot of drugs were delivered to Ukrainian hospitals. Also, equipment to two transplant centers were delivered. And what is very, very important, today we have a possibility to do a very good diagnosis in one of the best laboratory in Munich. And today, samples across the whole country are delivered weekly for cytology, cytogenetic, immunophenotypic, and molecular analysis to laboratory MLL in Munich, and the results available free of charge within days. And what is very important is that transport of blood samples organized, and they're financed by our European and American partners. It's ISTTC, EU Foundation, and WBMT, and I have to thank all of them. And here you can see the amount of analysis, blood tests that were done and we received from the August 2022 until March 2024. More than 4,000 analyses were performed. And it's no picture here. Now we will move. The number of transplant in Ukraine continues to rise. So you can see that in 2019 it was only 100 transplant, but in the last year it was 220 autologous transplant for adult patients and 69 allogenic transplant. And you can see that in first 6 months this year, the number of transplants is quite good. And also you can see how rise our unrelated hematopoietic stem cell transplant activity. Last year, 45 transplants were performed, and this year, near the same amount. And also, I will show you that the number of active hematopoietic stem cell transplant teams also rising. And now we have 10 transplant team. In year 2019, it was only 3. I understand that it's not enough, but we are moving a lot ahead. And this is our whole Ukraine activities of all 10 transplant centers, and you can see that most active are National Cancer Institute, Children's Hospital of Madrid, Cherkasy Regional Oncology Hospital, and Kiev BMT Center. And we have also a new one, it's Children's Hospital in Dnipropetrovsk and in Lviv, First Territorial Medical Association. And a few words of the results. We calculated some analysis of our mortality of first 100 days, and you can see that the most important was infection, both in autologous and after allogenic procedure, and also cardiovascular and bleeding in autologous, and relapse in allogenic transplant. And what I can say is that the state continued to finance the healthcare program, including high-tech and costly areas. And for more than 2 years of full-scale war in Ukraine, 522 medical institutions were completely restored, and 361 were partially restored. A new transplant department was opened in Kyiv these days, and also 2 new transplant centers were created at Dnipro and Lviv. And what is also important is that in the first 6 months this year, 48 more transplants were performed than in the first 6 months year 2023. And what is very important is that cooperation between hospitals saves patients' life. And I also want to show you one example. Rocket missile attack destroyed one of the largest children's hospital in Ukraine, and maybe the oldest one. And this hospital treats up to 20,000 children annually. And one of our transplant center, which performed allogenic transplant, located there. And you can see a picture before 8th of July and after. And the municipal authorities of the Kyiv city provided a new place for new bone marrow transplantation department, which was preparing to open. Some equipment has already been transported, and patients from the transplant department of Okmadit Hospital were successfully transferred to new hospital, to a new transplant unit within 7 hours, and were able to continue their treatment without any interruption. And the transplant team of Medical Center of Kyiv City, which provided a ready-made department, continue to work with their old condition. And we understanding that children are the priority. And as a summary, I have to say that collaboration that began with world leaders and organizations in the field of transplantation continued after this large-scale invasion and continues to develop. And high level, we also see the high level of adaptability to difficult conditions and experience of responding to such challenges. And despite the hostile environment, international societies, politicians, private institutions, World Health Organization, with the personal involvement of local physicians, Ministry of Health, provided an example how to establish a sustainable health system for hematological patients in the low-resource country in extreme distress. And this effort represents a model that by using solidarity and new technologies may greatly impact other countries affected by socio-economic and conflict challenges. And I have to say, all people who help us, my great respect, and say a lot of thanks to all of those who involved to help, and who continue to work with us day by day. Thank you.
Congratulations, Dr. Korenkova. Congratulations for your presentation, and most of all for your work. Thank you very much for all the colleagues that have been helping. We'll leave the discussion and the questions for the panel in the end. And if people want to type in questions in the Q&A, they can already do it. The second presentation will be Thank you so much will be by Dr. Amar and Ode and will talk to us about the Gaza experience. If you would like, Rosanna, to share your screen. Thank you so much for the presentation. It's coming up. Perfect. Thank you so much.
Good afternoon, everyone. This is Dr. Razan Aoude, medical oncologist at the West Bank, Palestine, Nablus. Thank you all for this webinar. And probably our experience is completely different from that one in Ukraine experience. And we'll show you this during the upcoming slides. In case we are talking about Gaza, we need to know what are the difficulties in Gaza Strip and where is Gaza Strip. Gaza is situated at the eastern coast of the Mediterranean Sea, bordered by the Palestinian occupied territories, and it's one of the borders is Egypt to the southeast, and it is surrounded by Palestinian occupied territories to the east and north. Gaza Strip is approximately 41 kilometers long and varies in width from 6 to 12 kilometers. Gaza is considered one of the most densely populated areas in the world, and it is home to approximately 2 million people, and it's considered one, again, of the most densely populated areas in the world. And it's worth to note that age distribution in Gaza is very different from that of other countries. We have a significant portion of Gaza's populations are young, with large percentage under the age of 25. And this has a huge impact on this age of population, as Gaza has been in conflict since 1948, and many Gazans have grown up in that conflict, impacting their education, their health, and their future prospects. Back to the history, Gaza has been under occupation since 1948. Since 1948, for almost 19 years, Gaza was under the control of Egypt, and that was the case till 1967, where Gaza was occupied by Israel, and that was maintained control till 2005. In 2005, Israel withdrew its troops and settlers from Gaza and retained control over airspaces, borders, and shoreline. And despite the withdrawal from Gaza in 2005, Israel continued to control Gaza in many aspects. And this continued control was on the borders, where Israel controls the majority of Gaza's borders, severely restricting movements of goods and people. And this affects the economy, where restrictions on trade and access hinder economic development and recovery efforts. Besides, movements in and out of Gaza is tightly regulated, impacting travel for Palestinians. And that also affects the healthcare system, where we have a lot of restricted medical supplies, limited access to essential medical supplies and equipment due to Israeli restrictions on imports. Besides medical personnel, where we have challenges in recruiting and retaining medical professionals due to the travel restrictions. And back to the restricted medical supplies, we have to say that Gaza have severe shortage of medications and severe shortage of diagnostic models, including imaging, including labs such as flow cytometry, such as cytogenetics and karyotyping. And regarding the infrastructure challenges that affect the healthcare system, we have a major problem in electricity and water, where irregular power supply and inadequate water infrastructure affects healthcare facilities' ability to function. Besides, we have poor sanitation conditions contribute to the spread of diseases, which is exacerbated by restricted access to construction materials for infrastructure development. Healthcare supply services are also severely affected by this control, where we have delays in emergency response due to movement restriction and, again, infrastructure limitations. Besides, we have difficulty in managing chronic diseases due to limited access to medications and specialized treatment facilities. This results in severe trauma and distress to the people and to the physicians who are living in Gaza, and that affects the level of care that can be given to those patients in Gaza. And as we said before, despite that Israeli get out from Gaza in 2005, there have been major 6 wars in Gaza since 2005 to 2024. These 6 conflicts have had profound humanitarian consequences, contributing to the ongoing challenges and crises in Gaza, including severe damage to infrastructure, loss of lives, and exacerbation of socio-economic and health hardships. Coming to this current ongoing war, as of 2023, the ongoing war has inflicted devastating consequences, including extensive destruction in infrastructure, homes, and essential services. The conflict had resulted in a high number of casualties, causing immense suffering and loss of life. Moreover, the ongoing hostilities have profoundly impacted all aspects of daily life, exacerbating a humanitarian crisis with shortage of food, water, and medical supplies. The quality of life for civilians has deteriorated significantly due to constant insecurity, displacement, and psychological trauma. This review was published recently in July 2024 in the Journal of Lancet, where the actual number of deaths that had been announced in this in Gaza up to this time around 40,000. However, they are expecting that the deaths will reach 168,000, and this is because of the severe damage in the infrastructure and the healthcare system. The government media office publishes an update for the most important statistics of the war in Gaza Strip till 12th of July 2024. 34 hospitals put out of service by the occupation, and we all know that Gaza has only 36 hospitals and 34 hospitals put out of service by the occupation, and around 10,000 cancer patients facing death and needing treatment. This image shows the attack on one of the hospitals at Gaza, where were completely damaged by the air fires. And the only cancer hospital at Gaza, which is the Turkish Palestinian Friendship Hospital, has been destroyed by the Israeli strikes at Gaza. The Palestinian Turkish Friendship Hospital is the only one for cancer treatment in Gaza Strip, was forced to shut down its services on November 1st after running out of fuel due to Israeli continuing blockade on Gaza Strip. The building has also sustained heavy damage from a repeated Israeli attack on the surrounding areas. There is also severe shortage of, as mentioned before, severely shortage of diagnostic labs, medications, and cancer treatment that existed before the war began. And the problem has only worsened and continues to persist up to the present day. And as we mentioned before, they have a lot of medications, where most of the hematology patients, the complicated cases, including the leukemias and the high-grade lymphomas, and patients who need a transplant, they cannot be given any treatment in Gaza. Even before the war, patients have to travel either to the West Bank or to Egypt to get their medications, or to undergo further evaluation and then management. However, the basic medications came out of had severely shortage of Gaza after the war, and months after the start of war, medicines have run out, including chemotherapy, biological agents, and other supportive medications, including pain medications. This disruption on the healthcare system affects a lot of the patients, where hematology medications, as mentioned above, are frequently in shortage supply of Gaza, impacting the treatment of patients with blood disorders. Before this war, the patients need to cross the border travel. Many patients must travel either to the West Bank and Egypt to get their medications. This had a lot of logistic challenges on the patients, where we have delayed referrals because many patients experience delays in receiving referrals to specialized treatment centers, affecting their treatment outcome. Travel permit process, every patient that needs to be traveled, they have to have Israeli permit in order to go out of Gaza. However, a lot of patients are being delayed or do not giving any permit to travel to the West Bank or to Egypt. And besides the travel costs, there is a very high cost associated with the travel for patients, and sometimes their sole companions due to the permit restrictions. And considering the social issues where separation from the family, as only either the patient alone or patients and only one companion is allowed to travel with the patient, leaving behind their family members who also need to relocate for extended periods during that treatment. And this is my presentation, and Dr. Riyad will came across the effect on BMT at the West Bank.
Thank you very much. I'm going to stop sharing this block of slides and share another one.
Thank you, Dr. Amr. Just got that to the presentation mode, please?
Can you still hear us?
Yes, perfect.
Yes, thank you very much. This is where Palestine is. It's in the center near Africa, Europe, and Asia. This is where Ukraine is in this area, not far from there. Palestine is a very small country. And this week, we go back to history. The green is Palestine in 1946. Then Israeli occupied some of Palestine and changed the name from Palestine to Israel. Then Israel took more areas and they call it Palestinian territory, not anymore Palestine. Then now we have these green areas where we have Palestinian people living there with their control. This is Gaza, which is around 140 kilometers long and about 6 to 12 kilometers wide. And this is where we are in the West Bank. We both are under occupation, and people who coming from there have to cross Israel and then come to the West Bank. This is our hospital in the West Bank. Although it's a tertiary hospital and it accepts referrals from other parts in the West Bank and from Gaza Strip, it has only around 160 beds, with the main specialties include hematology, oncology, BMT, auto-BMT, nephrology, and other facilities. Up to the 7th of October 2023, around 1/3 of referrals to our hospital were from Gaza to different specialties. Traveling from Gaza to the West Bank, as Razan said, needs special arrangements with the Israeli authorities. These arrangements can take days, sometimes weeks, even months, and sometimes are refused completely. This can cause delay in the treatment of some patients, and sometimes we lose patients before managing to get through to the other side of the border. Since October 2023, no patients managed to reach the West Bank at all, zero transfer. Some of those patients were planned for auto transplant and have lost their schedule, who are still waiting. No news about their health now, and we cannot communicate with them to know what's happening with them. Many of these patients, many of other patients were supposed to continue follow-up after we have done auto-BMT for them, but we lost their follow-up program, and also we don't know their care and their condition. Some patients lost their lives after being potentially cured of their disease. This is our list of transplants starts from patients number 1 to 250, nearly 250. Number 8 here is Sarah Shaban, who was transplanted in August 24, almost 10 years ago. But this is Sarah Shaban talking in Arabic here herself. And this is the Google translation where she was afraid of something happening to her and was asking God to protect her and forgive her and pardon her. Sarah got married and got a child. By December 23, people started talking about Sarah. Sarah is no more alive. She was killed, bombarded, and killed her husband, her daughter, and all members of her family. No one was managed to escape. This is one example we know of. There are many other examples which we cannot follow and trace them. Okay, the data I'm going to present is up to June 2024. We only do autologous transplant, high-dose chemotherapy with stem cell rescue. The first transplant, as we said, was in June 2014, a total of 345 cases, on average around 35 cases each year. It varies. Some months we have a peak of 40 cases, 45, and sometimes it drops down. This distribution of patients is between 3 main diseases: Hodgkin's, non-Hodgkin lymphoma, and multiple myeloma, and the minority with other diseases. The range of their age is between 16 and 70. There are other children, but they don't belong to our team. The median age is around 33 years. The gender distribution, 43% were female and females, and 57 males. Distribution from the place where they come from, 30%, around 100 cases from Gaza, while 70% from the West Bank. That is up to October last year. This is one of the patients from Gaza who was transplanted early in about 10 years ago, and she's still alive, or she was alive until a few months ago. We don't know what happened to her later on. The 100 days mortality was 2.6%. We lost only 9 cases due to chest infection, respiratory failure, multi-organ failure, and 1 case of cardiac insult. This diagram is trying to show in this area, this is a 4 months block. Each block is 4 months. This is the blue one is the total number of cases. The brown is the patients from the West Bank, and the yellow patients from Gaza. And we notice as we go through towards the end of last year till now, we only managed to do 1 transplant in 4 months period, 1 transplant in the previous 4 months period, and there were about 3 transplants there because they were already in the West Bank. This is the same example that we have 3 transplants by the end of last year, 15 from total 15 from Gaza, 3 patients, and from the West Bank, 12. Since then, we have been having one and no more patients coming from Gaza for transplantation because of the war. I would like to thank all the organizers for this meeting, and thank you very much.
Thank you very much, Dr. Amr and Dr. Odi. Thanks for your presentation. Now we'll be listening to Dr. Hamad, who talked to us about the role of the BMT organizations and the WBMT, and then we'll open the panel. Thank you very much, Dr. Hamad.
Thank you. I'm going to attempt sharing my screen now. Hopefully this works. We'll just go to presentation mode now.
Perfect.
So thank you, everybody, for attending this amazing webinar. It is an absolute honor and a privilege to be sharing this session with the speakers that preceded me, and very sobering to hear from them. And I hope people can appreciate that. So my role in the WBMT is I am one of the co-chairs of the GINA Committee, or the Global Emergencies and Nuclear Accidents Committee. And it is befitting that we are talking about these global emergencies, whether they are man-made or not. We used to work mostly with nuclear accident issues, but I think in the context of not only COVID, but war zones, conflicts that are ongoing, it's really important that we are aware of the impacts around the world, particularly in our own particular field. I work in Australia, in Sydney. I was born in the Middle East. I've lived in most countries, including Europe and North America, Australia and New Zealand. And I feel like I'm a child of the world. And so my perspective and my view on global issues is one that's born out of experience and connections with people from many different countries, including the Middle East and Palestine in particular. I personally live on Gadigal land here in Australia, and I'd like to acknowledge that I am an Indigenous land. With that, I want to reflect on some of the things that I've heard today. And I think in any setting of crisis, as human beings, as adults, we've all learned how to support one another in one way or the other, whether it's friends, it's colleagues, it's family members. In a crisis, there are certain principles that apply. And I think in magnitudes of crisis, when crises are very large, it is very challenging to even begin. And so what I'd like to do in the next 10 minutes is take people across the journey of how should we think about a crisis and how we can assist. What can we do as individuals, as professionals, as organizations, and as WBMT, and then start to make individual and then group-led initiatives to try and help and support our colleagues. My feeling, and these are my opinions, based on not only being a human being, someone who's a member of a family and has my own children, is that at any point in crisis, even as a medical professional, it's really important to engage in active listening, in validating the experiences of those in a crisis, because that in itself is therapeutic. Listening is in itself a therapeutic and valid way to support someone. I think the next step is to ask, how are they best served? It is not for us to determine how to help people, but to find out what they need and what we can deliver. And learning about what's going on for them is really important, but doing so without adding burden on them. So sometimes we forget that people in crisis do have a limited bandwidth, limited energy, and limited resources. And so if we are able to take the burden of learning about their circumstances and in their environments without actually burdening them, that is something that we can also do. I think it's important to offer help, but offer help that you can actually offer, that is deliverable, because empty promises can be a challenge. But do what you can and then follow up and do so with deliberate intention on delivering. And I think those principles should be something we can all agree on. I'm sure everybody has their own strategies, but this is how, in my mind, I'm trying to frame how do we engage around something so complex. So I'll start off with what the role of the WBMT is and what is WBMT. WBMT's mission is to optimize the global development of transplant and improve patient outcomes worldwide. It is a bold and it is an ambitious goal, but it's one that we have been trying to deliver with collaboration with numerous other organizations around the world. Our vision is to be the leading global network promoting safe and effective transplant. And of course, in the context of conflict, safety is a major concern, and therefore it is part of our vision to be able to support those activities. I want to draw your attention to the very busy side on the right. That is the list of member societies of the World Bone Marrow Transplant Network. These are the groups of people that we engage with on a regular basis. And I think this is very admirable. This gives me faith in humanity that we are able to engage globally as professionals around a singular goal around the safety of transplant outcomes, around access, around improvement. And this is what we as professionals exemplifies transplanters, because transplant is a global activity. Transplant crosses borders, patients and donors cross borders all the time. And so it is befitting that as the World Bone Marrow Transplant Network, we are engaging with colleagues and societies and organizations around the world. And most importantly, we are an acknowledged affiliated organization with the WHO with a specific committee, which I will get to. So where to begin? My feeling is, as individuals, after hearing what we've just heard, it's very hard and confronting to absorb all of that information and to feel that there is something we can do. As individuals, we can start small. We can read and learn about the areas of conflict and reflect on where we are in the world and where our privileges lie, what resources we have and what others may not. I learned a lot today, not only about the geography of the two locations that were spoken about, but also about the history. And I think having that information delivered is really easy, but it's also important that we go out and learn and listen and avoid ignoring the news when we hear it, but actually to listen and reflect and think about what other people are going through. Having said that, that doesn't come without burden. As many of you might have heard, on planes, you should put your own oxygen mask first. I think it's really important to manage one's own moral injury. Listening to those stories, seeing those pictures, it is hard for everyone and it causes a lot of emotions that we must be able to manage, but we need to manage that before we reach out to support, because it's unfair for the recipients of support in a crisis to have to manage our moral injury and distress. So look after your mind, look after your heart when you are reaching out so that you are able to be there for someone else. And so reach out when you can, ask what is needed, leverage what you have in terms of your privileges and resources. Not everybody has infinite resources or access or connections, but you can do what you can. As professionals, I am always thinking there's a difference between what we would do as people and individuals and what we can do as professionals. I think one of the most important things is to be open-minded to the realities that we would think are unthinkable. be open to other perspectives. The way people are resourceful and creative in how they manage situations is something that we can learn from, but we also can support. It's very difficult to set standards of care that are unachievable for others and expect those, expect people to meet those standards in areas where it is not achievable. So being there to support decision-making under constraints is something that is very validating and is part of that validation and acknowledgement of experiences that we can deliver as professionals. We can support clinical decision-making, support policy and strategy in certain restricted spaces, and this is achievable. We've heard from the story in Ukraine about how they were able to actually open centers in transplant in situations where otherwise you wouldn't expect that that would happen. So there are ways to support people in doing the things they need to do efficiently, effectively, and strategically. As physicians and clinicians, teaching, mentoring, and sponsoring is something we are all capable of doing. And I'm very grateful to have had the opportunity to meet the people in this webinar, because I've been able to speak and sponsor and elevate as much as I can. And it's important to be able to acknowledge that that in itself is worth doing. And if you're able to do it, please reach out and do so. So the bottom line as professionals, I think, is do what we can when we can is really a very achievable goal. In terms of organizations, I think organizations have a wider reach. I think as organizations, we can be brave, we can be humanitarian and stay true to our mission. This is exemplified by the statement that was released over the Ukraine by EBMT and ASTCT and WBMT. It was a joint statement, and it allows giving a voice to the voiceless. I think organizations can do that, and it's very powerful to be able to do this, not only to validate the experiences of what's actually going on the ground, but to actually chronicle what's happening in the position and how this reflects on our mission as organizations. I think as organizations, we can recognize, acknowledge, and celebrate those who lead, and celebrating them is important, acknowledging what they do. The people we heard from today are extraordinary human beings working under extraordinary circumstances that requires a significant amount of celebration and acknowledgement. But we need to support and stand by those who lead. We need to offer them platforms and support that is tangible. And organizations have networks that can do that. The WBMT has been incredibly successful under the leadership of Dr. Niederwieser, looking at how we can support as an organization Ukraine in its circumstances. And that work has been tremendous because it brought together multiple organizations. It leveraged the networks within WBMT and the connections within WBMT, not only to educate, collaborate, coordinate, but also to advocate on a regular basis. And that effort is why it's successful. It is a deliberate and coordinated approach with multiple organizations. And that is collaboration from physicians and from organizations at its best. As a WBMT, I think we have learned many lessons from the Ukraine and our collaborations with the WHO and collaborations with other organizations. This is one of our strengths. Data collection and dissemination, importantly, dissemination of information is something we are very good at doing, particularly through webinars, through publications, through writing. It is something that we are able to utilize. So it's important for us to keep that in mind. We have a number of committees with significant global expertise from all around the world with different perspectives that honestly, it blows my mind, the diversity of groups and clinicians and countries in every committee that has something very productive and very practical to offer. And so we should really be using these committees to support wherever possible. And some of that is just making sure people are aware that these are the committees that we have on board and what we do with them. We have networks with other societies, as I mentioned before, but we also have reach beyond societies, including with organizations such as the WHO and connections with government bodies and country officials wherever we go. So I think it's important to acknowledge that the reach is not just professional, but it's beyond professional and allows us some advocacy networks that are usually inaccessible. So as organizations, and particularly as the WHO, we certainly have reach that we would like to be able to use to continue to support areas of conflict. In terms of the committees, the Global Emergencies Nuclear Accident Management Committee is very interested in supporting transplant services or activities around areas of conflict because they're considered emergencies. And, global emergencies can be man-made in terms of war. They can also be natural disasters, can be major pandemics. And we saw through COVID what global emergencies can look like beyond what we would expect in nuclear accident management. There are multiple committees that work on education, that work on quality, and look at donor issues and donor safety, which would be very relevant when donors are crossing borders or patients are crossing borders. And of course, we have huge talent in the nurses committee that can support nurses on the ground wherever they are, and the WHO liaison committee, which is also very, very helpful. So where to next today in this webinar? Well, I think we have done some listening. I'm hoping that we will do more active listening and validation on our panel. We will be asking our panelists about their perspectives and how do we learn more about these issues? Is there a way for us to engage in a way where we can get access to information and then support our colleagues without having to burden them? And how do we support them practically? What do they need from us as organizations, as professionals, and as individuals? And hopefully at the end of the panel, after the discussion, we will be able to summarize this information from today and be successful in disseminating it so that we can chronicle this event in its magnitude and also to give it the honor it deserves. And with that, I'm going to move on to the panel. So I'm going to stop sharing my screen and I'm going to ask our panelists to turn on their cameras.
Thank you very much, Nada. We already have one first question. Is asked, please, Alexander, to tell us how the hospital managed the immediate needs after the bombing of the BMT unit on July 8th.
Thank you, Adriana. What I might do is I'm going to tell the panel how we're going to run this because it's going to run over probably half an hour or so. And what I'd like to do is start by asking about the recent crisis in Ukraine, and then I'm going to move through the panel asking questions, and we will start to get questions from the audience, hopefully towards the end there, if that's okay. With that, I wanted to welcome some of the panelists who didn't get an opportunity to speak, and you have met them earlier in the day, but they will introduce themselves as they start speaking also. So I did want to start with Alexander because, I think it's very difficult to ignore the fact that we've had a recent crisis where a hospital was destroyed. And this happens not too uncommonly, as we've heard from our colleagues in West Bank. But the fact that we couldn't even reach out to Alexander was quite challenging. It was in itself quite stressful because not knowing how safe he was a moment in time where you get that sense of moral injury. So Alexander, it would be very nice to hear from you to find out A, are you safe, and B, tell us a little bit about what's happened and what the plans are for your service.
Hi everyone. First of all, thanks a lot for inviting me to talk, and I also thank to all of the speakers today and organizers of this event because we are now addressing the whole another side of BMT care in the conflict and war zones. My name is Alexander Istomin. I'm pediatric hematologist from bone marrow transplant and immunotherapy department at the National Specialized Children's Hospital Ahmadi. So as Dr. Karinkova already mentioned, it's one of the three major BMT centers in Ukraine, which provides all types of hematopoietic stem cell transplants. And yes, last Monday, 8th July, we became victim of a very horrific terroristic act while the rocket, the missile hit our hospital, totally destroyed one building that was served to treat patients with who require hemodialysis, with patients with chronic and acute intoxications, and it also had an ICU department. So one part of our new building that you may saw in the pictures of Dr. Karinkova is severely damaged by a blast wave. So, and it really affected our ability to continue transplant activity because of the severe damage to the ventilation, to the windows, and as soon as it happened, I realized that all of the department is in shrapnel, debris, smoke, and it was terrific for us to think about maybe some repetitive strikes. So thanks to our colleagues, thanks to our Ukrainian people who are willing to help, we managed to change the place, to change the location within less 24 hours. It was challenging, however, it also can be addressed that in such circumstances, when the issues of the sanitation and air purity and all of this ventilation issues, if it happens, you should work pretty fast, because the patients in severe aplasia during conditioning regimens, they cannot be treated in such conditions. So they should be transferred as soon as possible to wards with specific HEPA filtration and so on. That's why, thanks to the Kyiv local authorities, we pretty promptly found a new place which can give us these conditions for our patients. And for now, luckily, we had no delays with transplants. So we planned last week to perform at least 4 transplants, and all of them been made. And we are really happy for that. Also, luckily, the rocket didn't hit the main building, because if it happened, I think it would be the consequences would be way worse. So for now, we are thinking about when we can came back, and we hope that that this renovation of our hospital will take maybe up to a few months. However, it's not my area of expertise to claim, so maybe it will be even more. But luckily, I would say we have no casualties with our patients, no casualties with medical staff. And this is also because of the, I would say, the good architecture of the building, the good architecture of the very department, because we are isolated from the outer world with 3 layers of windows and walls, which I think basically saved my life. And saved the lives and health of all of my colleagues who've been working on that side of the department. Luckily, also, our day clinic is okay. So we started admitting the outpatients in our day clinic. Some concerns about the the surroundings, because another story for that is the dust. It's a construction site that is going right now near our hospital. So that is something that we also addressed with increasing and changing the antifungal prophylaxis in these patients. However, what I can say that it could be way worse. Luckily, thanks to our colleagues, we're now in a better place than our facility right now. I can hear you.
You're mute.
Nada, you're muted.
There you go. That's better. I just wanted to say, Alexander, thank you so much for sharing that experience. It can't be easy sharing a traumatic experience like that. And I'm personally glad that you're alive, as I'm sure many of the colleagues on the line here today. And it is just extraordinary that you managed to continue those transplants under those conditions. And what it says to me is that there is a lot of preparedness, possibly collegiality, collaboration, and really moving really fast. And that has to be with a lot of prepared ideas of how you were going to execute this. So I'd love to hear more about that element of how are you prepared? What does the preparedness look like? And what kind of role do organizations like WBMT and other organizations play in that preparedness? And perhaps you and Irina can comment.
I can start that the first main task for us at the beginning, few minutes after the missile attack, it was delivering safety to our patients. So all of them being moved to the safe place. Some of them still were inside of the building, but in the place where there are no windows, and there are no concrete damage to the windows or floors whatsoever. And the other part of the patients were moved to the basement, basically. So addressing the safety was the issue number one for us. And after that, when we calmed down a bit and started on thinking about what to do next, so we thought about evacuation, and it's something that came up to our minds because of the previous experience during February and March 2022, when Kyiv was seized by Russian troops. And in terms of the international collaboration, we had a really great experience with St. Jude Safer initiative, and that helped to not only to evacuate patients, but to maintain their treatment abroad, basically for free. So it was free for the patients, and we still in contact with those patients who've been evacuated during winter 2022. In this case, the first thoughts were about evacuation on who will go where, which patients can be transferred to other hospitals, which patients can be transferred to maybe abroad. But after that, we understood that maybe it's not that tragic, and maybe we can find some local solutions for that. And once again, without involvement of the local authorities that provided us this opportunity, well, I think we would be back to the first option, to the evacuation. However, just because we found a new place within 2 hours since the missile attack happened, that helped us to start packing everything we could pack and take with ourselves. We start disconnecting patients, working with CV lines, packing our drugs, supplies, whatsoever. So in the first wave, we evacuated patients, staff, and injectomates, drugs. So just the minimum we need to continue on infusions, to provide chemo, and so on. So this was the first wave. On the second day, we proceeded with more basic things like shaker for platelets, like other medicine supplies that were not so urgent for us. And for now, I would say it's pretty comfortable to work in here, and it's also comfortable to work in here because this place was built with BMT in mind, I'd say. So this is a new department that was made for the Kyiv Bone Marrow Transplant Center, who should come here last Thursday. Unlikely these events happened and we moved to their new place. That's why it's also referring to your comments on international collaboration, because what I think, and I knew that Dr. Irina Korenkova and Kyiv Bone Marrow Transplantation Center, they work closely with WBMT, with EBMT representatives, and I'm pretty sure they discussed also the architectural and engineering plans for this place, and it looks pretty, I would say, solid and pretty modern for providing such therapies as bone marrow transplant. So to sum up, I would say that to be prompt is essential in this case. If you have no casualties, especially if you have no casualties with your patients in terms of receiving traumas related to missile attack, it's kind of doable to make it fast, because all you need is a place where you go. You need a transport, and you should be reassured that the transport is okay, that you have that its capacity will be enough to store as much luggage and personal items, both medicine and supplies, and that is the minimum that you need to make it within 5 up to 7 hours. So at the same day, we already had the patient rounds at 10 p.m. So our workday ended like near 11 p.m. However, all of the critical job been done during seven hours, I'd say.
That's extraordinary. And I mean, it's a testament to how well structured and efficient you have been in managing this conflict and this issue under severe circumstances. Irina, I'm interested in, do you have protocols in place from an individual perspective? And then I'm going to throw to Stratos to ask about what are the kind of WHO or global protocols available in circumstances like in Ukraine and in Gaza and West Bank. Irina, do you have internal protocols on how prepared you are should something like that arise? Where are you going to go? What are you going to do? Some kind of embedded strategy?
No. I have to say that we are really preparing for such possible situation. We have prepared evacuation plan for, and we know each other's who work in transplant units very well, and this for us was maybe a good idea for preparation. Of course, it's a terrible situation that happened with Okhmadit hospitals and hospital, and we are happy that they can manage, and we will involved in this process. So of course we don't want to repeat such a situation.
I think that's the challenge, is reconciling not wanting things like this to happen, but needing to be prepared is still important. Stratos, can you give us some insights from a global point of view about protocols for when you receive information from areas like Ukraine and Gaza and West Bank? What is the sort of protocol internationally in terms of how these areas are supported and prepared?
Well, thank you very much. First of all, let me just express my sympathy to all the situations, and of course, my congratulations to the resilience of the people in continuing the care, and of course, from a WHO perspective, to condemn any targeting of healthcare facilities in such situations. As you rightly mentioned, Nada, of course, crisis is a broader term where we can have also natural disasters, we can have pandemics or other situations where you have a disruption of the service. So from WHO perspective, I mean, we have, as a UN agency, we are working under that general broader framework of the UN humanitarian protocol, which is coordinated by the OCHA, the OCHA, which is the Office for the Coordination of Humanitarian Affairs of the UN. And they are the ones that coordinate all the issues when it comes to country-specific or region-specific situations. For instance, in Gaza, we have been working mostly on the provision of medication, consumables, and devices, although we have the problem of actually delivering them due to the restrictions and the different embargoes that have been in place by the Israeli government. So the problem is indeed, even from an international organization perspective, that we also have some limitations which are mostly based on the political situation, especially when it comes to the conflicts. Indeed, as you mentioned earlier, one of the issues is preparedness and resilience. We have issued in 2023, in April 2023, so a year ago, some specific guidance on resilience and preparedness plans for blood services. and transfusion, which might be relevant, of course. And I would add the link if you want to that document. And one of the things that we have been discussing with the WHO Liaison Committee of WBMT is to produce such a protocol guidance document that will be specific to the issue of transplantation. Unfortunately, the situation is that, of course, we cannot exclude or focus on a specific healthcare issue. We have to look at it from the broader perspective and all the disruptions. So there hasn't been any specific plan on transplantation or hematology. This is mostly coordinated at the country level by the government. Because we cannot reach, of course, the areas on the ground, and we cannot have that sort of assessment or feedback. We try to deploy teams where possible. And of course, there are many, many actors apart from the UN. There are a lot of humanitarian agencies and non-state organizations. Specifically in Gaza, we have 63 partners on the ground. As it was mentioned, there was Turkey that had set up an oncology center. And this is similar, of course, in Ukraine. There were many actors at the time. Practically is either work with them and those teams by providing them the resources where possible, or collaborating with them because we do not have our own teams that will be deployed on the ground. We have also a protocol or a framework, if I may say, on emergency medical teams, which is about establishing this kind of teams that will be deployed in such situations. And this is something that we can also study. Of course, this is not the case perhaps now with WBMT because you're not actively involved on the ground. Although, I mean, there are three different ways of involvement, but you could still coordinate either the provision of resources or the facilitating the continuation of healthcare in the country, in the specific location, or abroad, which will include the transfer of patients. This is a bit more complicated because, of course, you do not have the power as an NGO to actually negotiate transfers or coverage of the patients. As it was mentioned from the colleagues, in Palestine, the patients have to travel to cross the borders between the Gaza and the West Bank in order to reach the facility. So this is very difficult because this is where we need a political cooperation, of course, which is something very difficult to gain at the moment. So we have to look at it from the very, case by case specific, although there are these hierarchy principles. We will continue, as I mentioned, to collaborate with WBMT. We have plans for further enhancement also of the personnel by training, providing professional training and capacity building. But of course, we need to prepare that sort of protocol, a global protocol for the prevention and continuation of care during crisis. Thank you.
Thank you so much, Jaros. That is a fantastic overview and explanation of how important it is to actually efficiently coordinate, because in a situation like this, everybody wants to help, but without active collaboration, open channels of communication, and coordinating activities, it may not be as efficient or effective as it could be. And certainly it sounds to me like in Ukraine, that's one of the strengths of the processes that occurred. There was a form of coordination and certainly very open channels of communication. It strikes me that in the situation in Palestine, what I've heard from colleagues is many patients have to leave the country or exit to get access to services, whether it's to Israel or to other countries. We have two colleagues here on the panel who have received patients like that. And I'm going to go to our colleague, Dr. Salwa Saada, to talk to us about the experience of receiving patients and what the communication or the lines of communication are like when you're looking after patients like that. And then I will move to my co-chair of the GINA committee, Shahrukh Hashmi. Salwa, please let us know what it's like to receive patients and look after them in circumstances where things may be so challenging politically.
Good afternoon, everyone. So first thing, I just want to make a comment that the situation in Gaza, although there is an acute catastrophic process going on right now, but it's not an acute issue. It's a chronic issue with, like medicine, we like to say an acute exacerbation. That the suffering of our patients from Gaza has been a long-term thing, and it's a long-term suffering over years and years. It's only been worse with the acute crisis going on since October 7th. And kind of to get that picture across, I do want to use one of my patients as an example. So I have this college student who's 21 years old with aggressive B-cell lymphoma, relapsed after his initial treatment, and he was referred to KHTC for salvage therapy and an auto transplant. He's been through that course, the only one that was able to travel. This is before October 7th. The only one who was able to travel with him to be his caregiver during his treatment here is his 76-year-old father. So imagine a 21-year-old being taken care of during his acute pre-transplant and post-transplant course, and the only caregiver there is his father. He's been through his auto transplant, went into remission at the beginning, but unfortunately he relapsed at day 180, almost day 180 post-transplant. Now the only other option that we had to offer him at this point was an allo transplant. Again, his father was the only one available. He has 6 siblings. One of them, who was living in Egypt, was able to come to do his HLA match. And his other 5 siblings, we couldn't even see if he has donor or not. That was unfortunately after the October 7th event. And so we couldn't do HLA testing. His brother, fortunate enough, was a haplo match, and so we could go through the transplant. And although he got through the acute post-transplant phase, with many complications, he had GVHD, he had infections in and out of the hospital. There are days where he has zero interest in receiving anything, because sometimes days go by before him knowing what his mother and his other siblings in Gaza are going through. He has no news. He has no comprehension of what's happening. And communications are cut for days. And so in addition to all the medical burden and medical complication he has to go through, add to that all the psychological stress and trauma he has to go through, along with a 76-year-old caregiver who's going through the stress of his son's acute medical condition, and then his family who's left back in Gaza. And that's a transplant patient. We can go on and on about stories of non-transplant patients and other transplant patients with similar stories. And that just kind of gives us perspective of these survivors of the war, trying to survive their cancers and everything they go through. And I just leave that as food for thought. And yeah.
I mean, that is a really wonderful way to contextualize and for us to relate to as physicians who deal with transplants. We can talk about the gravity of the situation, the numbers, and the death toll and the loss of life. But when we talk about patients and their experiences, we can all relate to patients who are going through a transplant and that procedure itself. I love how you talked about the border crossing element, the international element, accessing donors. We often forget that to be able to tissue type siblings, we do need to access international borders. And in Australia, we are an extremely diverse country, and many of my patients have their donors internationally. And sometimes, they are from Palestine, they are from countries that we can't get access to. So it is a problem that affects us all in different ways, but recognizing the global nature of transplant is key in this situation, to make sure that we don't forget that it is about accessing donors and people willing to donate. And that is really the magic and the humanitarian element of transplantation. It involves the gift of giving bone marrow and a source of life to patients in need. I'm going to move to Shahrukh. You have worked in many places. You're a man of the world, and you have experienced many healthcare systems and services. What is your experience of looking after patients who have been displaced, not only from Palestine, I'm sure, but from other areas? You certainly have a big passion for looking after patients with a global perspective on displacement. And I'd love to hear your thoughts.
Sure. Thank you very much, Nada. And certainly is a huge issue, as we have heard. And currently, the numbers of the internally displaced people and the refugees combined, and the people who have been displaced is more than a million. Actually, it's more than 110 million at the moment. It's for UNHCR. And this crisis is continuing to increase, unfortunately, all over the world. So in general, to answer your question specifically, and working in many disaster zones, going to earthquakes as well, in order to provide medical care myself, I can tell you that the triage is the most important thing. Now, a general triage of the vital signs and the general systems, if any emergencies are there or urgencies are there, is critically important. But by the time, if the displaced patients have been displaced by medical teams, and that's been taken care of. But then comes a specialized triage. And specifically in bone marrow transplant, it starts with allogeneic transplant versus autologous transplant. In allogeneic, in allografted patients, the first starting point is the timing from the transplant. And obviously, if it's already transplanted within a few months, it's wise actually that not to taper off the immunosuppression, because I'll tell you what, in real world, you don't get the records. You don't get the records at all, actually, in a lot of patients. And despite the efforts, when a true disaster happens in real world scenarios. So you got to make the best judgments. You got to make the best judgments from the family. They sometimes speak different languages, as much information as you can gather, and really triage the patients according to the time from the transplant. GVHD treatment, obviously, is one of the most difficult thing to do. And in case we do not know the medications, the simplest medications can continue. Even corticosteroids have to continue for these patients who have active GVHD. Now, the most difficult time is actually the ones who just got conditioning. And those are very few patients. But then if a disaster happens, a natural or an unnatural disaster, a war, earthquake, tsunami, what to do with them? They haven't gotten their stem cells and they've got a myeloablative conditioning. And we did publish a paper of emergencies from Ukraine, from the WBMT, in which we have some mechanisms of the world collaborating together. BMDW, WBMT, and many other organizations were in that paper. But we also published the paper for COVID-19 crisis and the pandemic as soon as it started, actually, how to deal with these kind of patients. And obviously, the alternative sources have to be sought out, not need to be perfect. Nothing is perfect in wars and in tsunamis and earthquakes. Got to make a best judgment. So that's the basic general principle of any particular allogeneic transplant patient. For autologous transplant patients, it's more of a disease thing if they have had it a long time ago, and restaging of the disease is mandatory one way or the other. And I've done that in many patients who had no records at all. And that's one thing that we have to do on arrival when you see these kind of patients who are displaced or are refugees. And lastly, let me just reemphasize on the point that in the current world, as much as we want, the crisis continues to increase, and the number of the UNHCR that we're monitoring isn't going down at all in many continents of the world. And that's why it becomes extremely important for us to have policies, international thought processes to tackle this problem proactively, because it's not just one or two regions. We're talking about the whole world here. Thank you.
Thank you so much, Joe. I think, going through the things in my mind that I think are the cornerstones of managing these issues, really around collaboration, coordination, and communication. You mentioned being able to communicate with patients, making sure that you can speak to them in their own languages. I think on a one-on-one communication is important. But it also sounds to me that communication on multiple levels is really the key. I'm going to go to Sylvia Montoto and then come back and speak to Razan and Riyadh. Sylvia, you have done some work around communicating and supporting clinicians in Palestine, and I think that is a unique experience in terms of how you were able to reach out and what you did there. So I want to hear what was your journey in getting to that place where you were able to assist and support? And what lines of communication did you use to be able to do that?
Thank you very much, and thank you for inviting me to this webinar. So my name is Silvia Montoto. I'm a hemato-oncologist consultant in London, and I am the chair of the Equality, Diversity and Inclusion Committee of the WBMT. And as Nada mentioned, I was involved in working with a charity in Gaza, MAP, trying to improve the care, the hematological care in Gaza, because as Salwa and Razan have mentioned before, a lot of patients from Gaza need to be transferred to either the West Bank or to Jordan or to other places to be treated. So the program was trying to improve the care in Gaza, improve the training and the teaching, because the professionals in Gaza are not easily allowed to travel to conference and to improve their expertise. And we also had a multidisciplinary meeting where we would discuss with the local doctors, and we will try to advise on their cases. This obviously stopped last October, and since then, one of the ways that we are trying to help is what Nada said at the beginning, is amplifying their voices and trying to make sure that the people are aware of conflicts. And I need to say something here that Nada mentioned before about the putting your own oxygen mask. Sometimes it feels like is a competition of what conflict is worse and why you should try to help this one and not the other. And sometimes I've been feeling the last months that there are other conflicts in the world that I don't know much, and I feel that I don't want to know because I wouldn't be able to bear with all that. And sometimes we are not superheroes. We cannot help in all conflicts, and we have to sort of concentrate on what we can do in one a specific area.
Thank you so much, Sylvia. And I can hear your desire to be of support to others. You're an incredibly empathic and giving person, and that is part of what we do as physicians. And so it can be quite a significant moral injury. I wanted to end the webinar by giving a voice to our Palestinian colleagues and giving them a platform and asking them, how can we help you? You've heard from us here as a panel. We have access to the WBMT, WHO, and a number of colleagues who are listeners on this webinar that are clearly interested in supporting and hearing about what's happening. It's important for us to understand what would help you the most. How do you think we can assist you? And I'll move to you, Dr. Amer. You are still on mute, Dr. Amer.
Thank you very much. Thank you very much. I think we're living now a devastating war. Nothing can heal while it's still going on. Absolutely. When we have 34 hospitals destroyed completely or almost completely, out of 36 hospitals, this is massive. When we have 40,000 people killed, that's 2% of the population. When we have another 10,000 missing, that's another number. When we calculate all of the missing, the injured, and the dead, it comes to around 7% of the population. This is massive. This is huge. Gaza is small. It's only around 360 square kilometers. So I don't think we're trying to rebuild the things while war is going on is going to help anything. I think we have to raise our voices very loud, not only the politicians, the academics, the professionals, or everybody, to stop the wars. Wars, wherever they come, they destroy. I think this is the main issue. Minor issues is we can ask WHO or whoever has control on the Israelis to let those people go out of Gaza for treatment, whether they go to Egypt, to Jordan, to the West Bank, or wherever for treatment. We know that their treatment level is almost zero. They cannot treat with chemotherapy, biotherapy, or anything. report a few days ago says that around 470 patients with cancers in Gaza died because of the lack of treatment. So asking, I know that everybody is trying to help, but the way we can really help is by stopping the war. Honestly, there's nothing else can help at all. Razan wants to talk a few words as well. Thank you.
Go ahead.
Thank you a lot, and thank you, Dr. Riyad, for this comment. I'm taking this opportunity to say that we are doing a very excellent job here at the West Bank. In the meanwhile, or in the way we are living here, we have a lot of shortage in medications and diagnostic labs and everything, and that because of the delays in supplying due to the medications. They have a lot of waiting time and to come from the from ships from Israeli borders here to the West Bank. We tried many times to establish an allogenic unit BMT here at the West Bank to help our patients here. We have around 10 patients who were here from Gaza and from the West Bank on the 7th of October. They were in need for allogenic bone transplant. However, they are forbidden to go to Israel or to Jordan to get their allogenic bone transplant. However, if we have this unit here at Palestine, we can help them here at Palestine. We have very skilled people and very skilled physicians who have they're trained in allogenic. However, we don't have an infrastructure for this. If you can help us in this and make sure that we can proceed with this, we will be more than thankful to you in order to establish a unit here at Palestine for allogenic bone marrow transplant.
That sounds like something that we have been able to achieve in Ukraine. We will do our best. I think everyone who's heard you here, Razan, and heard the information presented, the quality of care and passion you have in your voices for your patients. I don't think anyone has a dry eye in the house. I certainly am so moved by you sharing your experiences. And like I said, it's an absolute honor and privilege to be amongst people, human beings like you, that do what you do under their circumstances. I am very affected and touched by the stories of the patients you shared. You clearly know them as human beings and people. Those you've lost, I'm sorry. And I hope that we can all come together in this webinar to be a branch for you, a communication line for you in anything you need or we can offer. So, you know, I would like to congratulate you on the work that you've done. Salwa has represented you at the EBMT internationally. We are now here listening to you internationally, and hopefully people who have listened to this webinar have heard this story and are affected by it. Of course, Razan, I have to say that, you know, the Lancet Hematology was really interested in the story that was shared by Salwa when she came to EBMT. We will do our best to amplify your voice, amplify your story, and make sure people hear the kind of work that you do, because it deserves to be heard. And in terms of stopping war, while I'm sure that we all would like that to happen, all I can say is that we will do everything we can when we can to support you. And I'm hopeful that with any level of advocacy that we can provide from the WHO and WBMT, Damiano Rondelli, our president, is here right now, and I'm sure he might want to say something. So I know we're slightly over time, but I'm going to give you the last word, Damiano, because I think this is a really unbelievable webinar. I am so impressed by the kind of content we heard today. It is very powerful. I'd love to hear from you about your thoughts from what the WBMT can do.
Thank you, Nada. I know that we have only a few minutes, but I want to say thank you. And I want to say, I think what comes out of probably everybody's heart, that please don't feel you're alone. Please feel that we are here to do whatever we can in our capacity, which is limited, unfortunately, but is not is unstoppable. So as a WBMT, as individuals, as providers, as friends, as colleagues, I think I agree with Dr. Amer that we have to stop the war. That's the wars, not only all of them. Meanwhile, we need to raise our voice to help the patients today, to bring more supplies to the hospitals, to help protocols and agreements and the diplomatic efforts to move patients and families where they need today. Those are responsibilities that I think we as WBMT feel, and and is only valuable because we are together. So networking, connection, communication, I think is a very, very strong asset that we have. We showed that in Ukraine. We'd be very happy and honored to do that. The same thing with Gaza or with the West Bank or whoever is needed through our organization. So thank you very much for allowing us to be with you.
Thank you
so
very
much.
much.
And I'm gonna hand over to Adriana to close. And just I wanted to thank the panelists and thank you for being here. It is a tremendous honor. Thank you, Adriana, for being the opener, the organizer, and certainly thank you for the WBMT organizer, Vera and Romel, for putting this together under circumstances where everybody's around the world. The world is very small, and look at us all on the same screen. I will ask that before everybody leaves, we take at least a screenshot, just in case this recording doesn't allow us to do that. But I will take a screenshot now if that's okay. And I will hopefully be able to remember this moment.
Where the panelists and do not have their camera open if you want to open? If you have more people?
I think they're all open.
All right.
So just stare at the screen. We are done.
Thank you. Thank you, Nada. Thank you, everyone, for participating. We still have questions that were not answered. We have a request from Stratos to try to list what they really need that is objective, then we can work on. So we'll be doing it by email and WhatsApp later on. This will be recorded and posted on the WBMT website. Thank you very, very much for participating, our empathy, and we'll continue working to try to help whichever way we can. Thank you so much.
Thank you. Thank you.
And please stay safe.
Thank you, everyone.
Yeah.
Stay safe.
Bye.
Bye.
Bye.